So chest tube management. Introduction. Chest tube insertion is a procedure to place a flexible hollow drainage tube into the chest in order to remove an abnormal collection, whether it is air, whether it is blood, or whether it is fluid. This process is known as a chest tube insertion. Introduction. So traditional chest drainage unit consists of a collection chamber, a water seal chamber, and a suction control chamber. Depending upon the circumstances, a practitioner may insert a chest tube at the bedside or send the patient sometimes to an operating room as well, or a dedicated area for a chest tube insertion like a pleural clinic can be assigned to this procedure. What are the indications for a patient with a chest tube drainage system? So they are very general indications, like after a thoracic surgery or inserted for a spontaneous pneumothorax, like in primary spontaneous pneumothorax when already pleural aspiration has been done but still the air is more than 2 centimeters, then we need to put a chest drain. Or in the cases of secondary spontaneous pneumothorax, in which patient is symptomatic having a chest pain or dyspnea and the rim of air is more than 2 centimeters, then we need to put a chest drain. Or in a hemothorax, recurrent pneumothorax caused by a trauma, we need to put a chest drain. Or in a pleural effusion, when we are intending to put we are intended to do one pleurodesis, we can put a chest drain, or therapeutic, we can put a chest drain, or chemotherapy administration in some cases, like TPA, DNAs, talc. Okay, so this is a pneumothorax, that is air inside the lung. It could be hemothorax, that's blood, hydrothorax, infection, or hemopneumothorax, blood and air both. Where to put the chest drain? The site of the chest tube placement. It includes second intercostal space, mid-clavicular line. What are the contraindications for putting the chest drain? So there are no definite contraindications, but if there are presence of multiple pleural adhesions, presence of any emphysematous bulbs, coagulopathy like INR is greater than 1.5, or if the platelet counts are less than 50,000, then we need to see how urgent it is to put a chest drain, or patient is on anticoagulation, we need to hold on before, or antiplatelets, we need to hold on before proceeding towards the chest drain. But it all depends upon how important and how urgent the chest drain is. Risk may include, which we need to mention in our consent forms as well, infection at the site of insertion, bleeding at the site, subcutaneous emphysema, dislodgement of the drain, failure of procedures, lung trauma, perforation, visceral perforations, sometimes bronchopleural fistulas, and malpositioning of the chest tube. And we can go on by bleeding and others. What is the chest drain unit? So I think we all have seen this unit. It's also known as a pleurovac. Most commonly used chest drainage is a water seal principle, continuous wall suction, water seal unit, no wall suction. This system is basically consists of to collect the drainage, to create a water seal, to control a suction, and allows the air and fluid to escape from the pleural cavity but doesn't allow air to re-enter to restore a negative pressure. What we need to do after a physician marking a site with an ultrasound and positioning of the patient, like in this case patient is lying flat on the back with a hand at the back of the head, or in some patients sitting forward, leaning forward on a table with the pillows, or in some patient lateral decubitus positions can be used. This is the list of the equipment we need. Types of the chest drainage units. Standard. There are some portable as well. Standards are drainage of pleural cavity for air or any type of the fluid with or without the use of suction. It has a 2 liters capacity. It can be replaced when it is full, but ideally it should be replaced. Indications for use: following surgery that impact on the continuity of thoracic cavity, pneumothorax, pleural effusion, pleurodesis. Sometimes portable small CDUs can be used. They have a 500 ml drainage. It's more convenient for the patient to move around with those portable CDUs. Then there are induling pleural catheter, small size chest tubes or pigtail catheter in some part of the world can also be are also people doing it. Can be irrigated if occluded by healthcare workers and less traumatic. Then Heimlich's valve for flutter valves. Remove air as patient exhale. Valves open when pleural space pressure more than the atmospheric pressure, and closes when the reverse occur. Evacuate air from the pleural space to use for emergency transport, home care and long-term care units. So this is the chest drain unit. It has 3 chambers. First chamber is for collection unit. It receives the fluid and air from the chest cavity through the collecting tube attached to the chest tube. Second is the water seal chamber with 2 cm of water acting as a one-way valve, allowing a drainage out but preventing it the backflow. And third is the control suction chamber. So this is a suction control regulator. This is a collection chamber. This is a chest drain collector. This is air leak monitor. This is suction port. This is a manual high negativity vent. So continuous wall suction unit connected to a wall suction source uses a suction monitor below that balances the wall suction. A restrictive device or regulator is used to dial the desired negative pressure. No bubbling, no water evacuation. Water seal unit, no wall suction, regulated by height of water in the suction control chamber when connected to the wall. Usually 10 to minus 20 suction can be used. You should hear and see bubbling while it is working. This is another diagram how chest drain units work. So from the patient, fluid is coming. It could be air, fluid, anything is coming, and this is draining, and the air is passing to the water seal chamber, and from here we can apply the suction control chamber. So what are our colleagues' responsibilities to manage a chest drainage unit? Initial assessment is very important. Assess the patient's clinical status and vital signs, how the patient is doing. He should be hemodynamically stable. Encourage the patient to report breathing difficulty immediately. Explain to the patient that whenever he is feeling discomfort, or more coughing or chest pain or short of breath, he should be telling us so that we can see if it is blocked, the drain is blocked, or any other complications are occurring. Auscultate breath sounds in every shift. Diminished or absent breath sounds may indicate the lung has not yet re-expanded. Observe and report immediately the signs of rapid shallow breathing, cyanosis, pressure in the chest, subcutaneous emphysema, or symptoms of hemorrhage. Check the suction control unit if it's working properly or not. Make sure the drainage unit is stabilized and balanced around the patient, because it is very important. It could lead to the faults not only to the patient but to the suction unit as well, and to other patients as well. Check the tube connections periodically. In a continuous wall suction, the unit is connected to a suction source and gentle bubbling will be heard. So do check how fluctuations are being there. Check for intermittent bubbling in the water seal chamber, and if excessive bubbling is present in the water seal chamber, especially if suction is being used, rule out a leak in the drainage system. Encourage the patient to breathe deeply and cough at frequent intervals to help drain the pleural space and expand the lung. If the patient has to be transported to another area, place the drainage system below the chest level. This is very important, that this information should be given to patient, that if patient is being transported or to another unit or anything happened, this education should be given to the patient, that keep the drainage system below the chest level, as close to the floor as possible. If the tubes become disconnected, cut off the contaminated tip of the chest tube and tubing, insert a sterile connector in the chest tube and tubing, and can reattach to the drainage system. Do not clamp the chest tube for more than 1 minute during a transport. So check the dressing site for any infections. More important thing is that do not push the tubes back into patient if it's get dislodged. It's a very high risk of infection, so try not to do that. You can perform a daily chest x-ray, or clinical examination can be done to the patient. Assessment of the chest drains. Tube positioning. You can look at the chest x-ray. Look at the chest tube output. If it is less than 200 ml per day, according to the BTS guideline, we can think about removing the chest drain. If a tube stops draining, fibrinolytics can be used. Respiratory variations should be seen. See if there is any ear leak. Is it intermittent or is it continuous? Check the suction. Is the drain connected to the suction? How much suction is applied? Be cautious about applying a suction, because patient is at risk of re-expansion pulmonary edema. So, one information about the chest tube sizing and positioning. Recommended size are 14 to 22 for stable pneumothorax, 24 to 28 for tension pneumothorax, 28 to 32 for hemothorax or empyema. For ear, it's usually anteriorly and superiorly, and for fluid, it is posteriorly and inferiorly. Alternative to the chest drainage unit is flutter or Heimlich valve. Connect to the chest tubing and allow the fluid and air to pass into only one direction. Should never be clamped. Regulated suction can be attached to it if necessary. Valve drain into a plastic bag that can be held at any level, allowing the patient undergo chest drainage to be ambulatory simply by carrying that bag. This is the flutter mechanism. A suction control Stopcock conveniently regulate a vacuum to the chest drain, provide control of suction, bubbling, and allow the efficient use with any unregulated suction source. A stopcock must be in for initial system setup and should not be turned off during the patient use. Look like this. So a key point to remember, or whenever you have put a chest drain or you are looking after a patient for a chest drain, these need to be mentioned in the notes or need to be remembered so we can carry it out them. Check the water level every 8 hourly. Double check on initial assessment and before leaving your patient that all tubes are connected and balance and stabilize. Avoid lifting the drainage system above the patient's chest. Milking and stripping of the chest tube to maintain patency, it is not recommended. Never leave a chest tube clamp for more than a minute. Watch for leaks of air in the drainage system as indicated by constant bubbling. Stopcock should not be turned off during a patient use. Tell the patient to report breathing difficulty immediately and you can follow it up with a chest x-ray.